Welcome to the Kool Health Podcast, where we unlock groundbreaking research in health and wellness by bringing you the latest in health news and in-depth interviews with experts in their fields. We're here to make health cool again. All right, guys, we're back on the Kool Health Podcast. And for the first time, we're talking about something for the first time, and that happens to be all about bones. We've got a very special guest here with us today, a very well-informed and pretty well-trained guest. Honestly, it seems like he's been training his whole life just to be here sitting with me today. So, Dr. Doug Lucas, welcome to the show. A little bit about him, man. He's a double board certified physician. He is the status fellow in anti-aging and regenerative medicine. He completed his orthopedic surgery training at Stanford. It's a pretty good school. He's all into metabolic, functional medicine, epigenetics, everything we love here. He's on International Peptide Society. We're going to get into those. We're going to get into all things, guys, all things bones. Also, we're going to tie in some functional medicine stuff, some regenerative. He was in traditional medicine. He's now doing stuff beyond that. So he's got the whole 9 yards. Dr. Doug Lucas, thank you for coming on, man.
Thanks, man. Happy to be here. That's a robust list of things we want to get through. So we better get cruising.
And we're going to break it down. We're going to go step by step. You just dropped a book recently, correct?
Yeah. I've got it. You actually can't see it over my shoulder. So I have it right here. So this is a book. It's short, right? It's 150 pages. I wrote this book called The Osteoporosis Breakthrough because I wanted to provide something that I could tell anybody to go get. And of course, Amazon people have access pretty much around the world. And so it's basically like a jumping off point for osteoporosis for people that have recently been diagnosed, if they know somebody, or if they are struggling in their journey. It's a really great place to start because it breaks down kind of my experience with seeing how osteoporosis was managed in the traditional medical model as a surgeon, watching people have fractures and then just not get what they were looking for. Yeah. And then as I learned what to do in the functional space, what to do with, in the precision health space and genetics and peptides and hormones, like how all of that is such an asset to people that have bone health challenges. So wrote that to go along with our program. We have a very specific program for osteoporosis that is helping to reverse osteoporosis in lots of people every day.
Okay, that's a big word right there. But first things first, How on earth did you get interested in bones?
Yeah, so I have always been interested in the musculoskeletal system. So I've always been very active, done a lot of like sports, outdoor sports, snowboarding, climbing. I did some traditional stuff too. So always been an athlete of one form or another. When I decided to go to medical school after I was a professional dancer before that. So when I was dancing
professional
ballet,
dancer,
yeah, I was in the ballet world. So when I was in the ballet world, yeah,
that's awesome.
Back up, we can hit that. So when I was in the ballet world, I wanted to go to medical school to actually make some money, and so when I got in, I was first thinking something around the world of like primary care, manipulation, because I'm a DO. We're trained in manipulation. And then I was exposed to orthopedic surgery, and I just loved the black and white of it. This is broken. I can fix it. Being in the OR was really intoxicating. It's a really interesting environment. And we could do a lot of amazing things in the operating room. So I kind of fell in love with that and just chased it down all the way through the end of training, like at Stanford that you mentioned. And then I got into practice, and I loved the surgery side of it. But what I realized, and osteoporosis is a great example, but others would be, diabetes is one that I saw a lot of, and a lot of other chronic diseases, that our system is amazing at some things, but it is terrible at preventing and treating diseases like I just mentioned. And one of my skill sets that I really like, I love operating, but I also really love almost like investigative journalism. I love like digging into problems that don't seem to just sit right with me and seem to not be serving patients. And so I sort of went down this rabbit hole of getting more training, got another fellowship, that's the other board certification, and started to practice where we could actually treat some of these things the way that I felt like we should treat them. And that led into the bone health thing because of my background in orthopedics, because I fixed fractures for, I don't know, 13 years.
Yeah,
So yeah,
that's
so
amazing.
I'm very, very comfortable around the bones.
Right. And was there anything before you started working at the OR that triggered that, almost like it's a game day sensation in the OR? Did you play
Oh yeah.
what kind of sports did you do, or any mental
Yeah. Honestly,
motivations?
so the operating room experience for me was really more like a performance. So I mentioned ballet. So I started dancing when I was in college after some injuries from snowboarding. It's a really weird transition, I know. Um, and I was I dated dancers, and so they pulled me into the studio, and ended up marrying one too. And in that environment, you learn how to perform. And so, with performances, you do all the planning, you learn the choreography, it cold, you can do it in your mind, and then you walk out on stage and you just perform, and it's an amazing feeling. I
Yeah.
look at the OR kind of like that, where you've planned out a surgery, you walk in, you have the skill set, and you just execute. And that's what surgery felt like for me.
Okay, cool. And going into the OR in this traditional field, that's what it was. You saw a patient and you developed a plan for that certain patient and then executed, correct?
Right. And
Okay,
this is the space of the traditional medical model. And as a surgeon, that's what you're there to do, is to operate. But
understood.
since I'm here talking to you about other things, clearly there are other things that I wanted to do.
Okay. And when was that revelation that you decided, hey man, maybe there's more to this model, maybe there's more to research, this investigative journalism?
Yeah. So after we moved, I started practice in Colorado, and then we moved to Asheville, North Carolina, where I am now. I
Cool.
started practice in a private group, and it's a great practice, but it's a tough model because you essentially have to take call at a busy trauma center, which means that you're on call, you're doing stuff in the middle of the night,
Yeah.
and that's fine. That's what I signed up for. That's how I was expecting that, but I remember one case in particular. It was another diabetic case and as a lower extremity surgeon, because I did mostly my fellowship at Stanford was foot and ankle, and so would see a lot of diabetic patients. So they would call me when these patients would have issues, and so this patient needed to have his leg cut off, which is a common thing for extreme diabetes. And so 3 a.m, we're positioning this guy on the operating room table, and whenever you're doing stuff after hours, you always have a skeleton crew. Nobody wants to work, and the hospital doesn't want to staff the OR with people they don't need. And so it's just me, the nurse anesthetist, so the person who's doing the anesthesia, and a circulating nurse and a scrub tech. And the four of us
Wow.
are trying to position this patient on the table, and he's a big dude, and operating room tables are not big. And so I remember kind of being like up to my elbows in this guy's thigh, trying to like position him on the table so they wouldn't fall off. It's 3 a.m. The guy's like literally dying, and we need to get his leg cut off so that we can save his life. And I
Wow.
remember thinking to myself, what am I doing here? Right? Like, I understand my role to be heroic, and we did. We got the case done, and we saved his life, and he, went on to do okay. But the problem is that he would only do okay. That's the best that he could ever do, would be okay, because he already was severely obese. He had very bad diabetes. And what I learned about this guy, because I got to know him pretty well, what I learned about this guy is that he was following the instructions and recommendations from his medical team to the T, right? Eating the diet, taking the drugs, taking the insulin, doing everything they told him to do. And he was getting worse and worse and worse and almost died. And he was young, he was in his 30s. And so I knew the answer for him. I knew how to reverse his diabetes. My wife is a PhD in nutrition, and she does this in her clinic all the time. And I recognize that there is a place where I should be able to educate people and to help them to avoid this thing in the first place. So that was probably the first time I was like, I gotta do something else.
Absolutely. You were only reacting to the circumstances. You knew the preventative measures. You knew how to allow someone to not even be in that position.
Right.
And you had to do it. right?
That's right.
And that's the traditional model is phenomenal, just like you were referring to. You save that guy's life for the time being. And why do diabetics, why do they have to chop off or
Yeah.
amputate their legs again?
It's a great question. So one of the things that happens with out of control diabetes is that the small blood vessels will start to kind of stop flowing blood, and you could argue about why, but basically it becomes a small vessel blood problem. And so the tissues that are fed by those small blood vessels will start to get ischemic or necrotic. They just start to die. And
Okay.
so this guy had an ulcer, and this is really common in diabetes, is you'll get foot ulcers. So he got an ulcer that got infected, and the surrounding tissues got infected, and then that starts to go into the bloodstream, and it'll kill you.
Okay.
And so to solve that problem, you can treat with antibiotics, and you can potentially treat it locally. But sometimes when the infection is so bad, you have to just remove the offending thing.
Right. Okay. So yeah, understanding that, now you started going into further research. We're now looking into regenerative medicine and functional medicine.
Right.
Quick skew on what was that like? It was eye opening. Blow your
Yeah, it
brain.
was interesting because I was already sort of headed down that rabbit hole, but I realized that I needed some tradition, like not traditional. I needed some formal education. I needed a structured framework to figure out what of this is real, what of this is crazy. And so I went to a group called A4M, which is the American Academy of Anti-Aging Medicine, and they have a metabolic and functional medicine fellowship, which led to the board certification. And so I mean, hundreds of hours of training. And so I went part-time in orthopedics and did the fellowship. And this was kind of the beginning of the pandemic. So they switched, and I could do a lot of it through telehealth, which was great, or rather through virtual. And then got the board certification and started the practice kind of all at the same time. And so learning from the experts in the anti-aging and regenerative space was great because it helped me to create the framework that I ultimately created with how I treat patients now.
And looking into your book, looking into your clinic, I notice it's a very holistic and a very fundamental and practical approach to something that is disregarded as a disease and something that is life threatening. When I was reading that first chapter and you were running the statistics
Hmm.
on what occurs when someone gets a bone fragility fracture,
Yeah.
a hip fracture, I mean, it was, what was it? You get a hip fracture over the age of 50 and you die in 12 months? Was it?
Yeah. The mortality rate is so that's dying. The mortality rate is remarkably high.
Right.
It's 30%, which say, oh, that's not that high, but that's 3 out of 10 people, right? I mean, that's a really high number, and it is
Yeah.
higher than the risk of dying in 12 months for a woman. This is specific, but for a woman from breast cancer, any type of cancer,
Hmm.
right, except for a few rare exceptions. But definitely breast cancer, heart attack. I mean, all of the other things we talk about, dementia, and all these things that are the number one killers, osteoporosis, fragility fractures will kill you fastest. And it's the number 4 killer of people over 65. And yet we don't really talk about it. And the mortality, like the death part is real and it's worth talking about. But I think what's more important is actually understanding that the people that are worst off after a fracture are you could argue the people that have passed on, but actually the people that don't, but lose their independence. And this is what I saw over and over again, because the people that died, I didn't see again, right? I didn't
Right.
know. But the
Right.
people that would struggle, that didn't have good function, and for as a surgeon, you think, oh, well, did I do something wrong? Like, did the surgery not go well? But if you look statistically, it really doesn't have anything to do with the surgery. It almost doesn't even matter what the surgery was. Although, as a surgeon, I would like to think that's not true. But in general, they just don't do well because people that are at that point, they've let their bone, because they may not have known, but they've let their bone deteriorate to the point where they have no reserve, they have no muscle reserve, metabolic reserve, and then they just can't come back from it. So even if the surgery was perfect, they can't recover. And I would see it in hip fractures, but I would see it in other fractures too. And this is why when we treat osteoporosis, like I say in the book, like it is a big picture thing. You can't just look at the bone or the density of the bone and say, let's just aim at this one thing. And that's why that traditional medical model of here's a drug that's going to treat this bone density problem is not it. You have to treat the big picture. You have to treat the whole thing. Otherwise, you might make the bone more dense, but you're not making your patients any better.
Understood. So when someone has risks of osteoporosis or is starting to notice maybe their What are some common signs of osteoporosis
Yeah.
first?
This is one of the problems. There aren't any.
That's what I was going to
So
think. Like,
yeah, you don't know. I mean, some people will argue that there's potentially pain, and that's debatable. But for the most part, it's considered a silent disease, and you don't necessarily know unless you're screened with a test or you have a fracture. And if you had a fracture, then the horse is way, way out of the barn. The
yep.
problem with screening, though, is that screening doesn't happen in this country or anywhere in the world until way too late. So in this country, women are recommended to have a screening test, a DEXA, at 65 and men at 70. But I know, and I talk about this in the book, bone loss starts in your 30s and 40s. So if you have a bad starting point, you should really know in your 30s and 40s that you're losing bone, how quickly you're losing bone, and what your starting point is. If you wait until you're 65, man, you are at a really bad starting point. Now, you can still do something about it, but I would much rather, and I have a lot of patients in this group, I have a lot of women, especially in their 30s and 40s with severe osteoporosis that we're turning it around. And it's awesome. I'm so grateful for them that they didn't wait until they were 60, because they would be, likely post multiple fractures and essentially disabled. So, we're
Right.
able to really change their lifespan.
Okay. So most people understand that when I'm 65, I'm going to take this DEXA scan that you're referring to, and we'll see if I have osteoporosis. You talked about the DEXA scan. Let's get into what it is and, the effect of this DEXA scan.
Yeah. Yeah. So basically, it's a fancy X-ray. So it's a type of X-ray machine where you lay down on a table and this big chunky bar goes over you really slowly, and they tell you not to move. And it takes a few minutes, so it's kind of hard not to move.
Right.
And I just had one done because they also do the same thing for body composition. And so, you can look at, your visceral fat and percentage of body fat, et cetera. But it's essentially an effort to understand what your bone density is in your spine and your hips. That's the goal. And so this will get done, and then you'll get the report that says that you have two things in there. One is a T score and one is a Z score. And what these things are just statistical representations of the bone mineral density. The T score is a representation of your ideal bone mineral density in what would be early adulthood for your ethnicity and gender and a couple other factors. And then the Z score is age adjusted. So we use the T score in the traditional medical model to say, compared to where you should have been, we don't know where you were, but compared to where you should have been, where are you now? And so this freaks a lot of people out because it is arguably quote unquote natural, although I would argue shouldn't be necessarily, but let's call it natural to lose bone density as we age. You would expect that you would have a negative score, meaning you have lost some bone if you're 70 compared to when you were 30. And yet I see people that, they'll contact our team and they say, oh my God, I have the score. What do I do? And you look at the score and
Right.
you're like, oh no, actually this is stone cold normal for you. In fact, it's actually above normal. Like you're actually better than most. So I think the DEXA, when it's not interpreted correctly, can really be a negative thing, and it can cause a lot of anxiety. And then there's also a lot of issues with the DEXA, meaning that there's some variation from machine to machine. There's variation depending on the position that you're put in on the machine. So, you could get some, it's subtle, but you could get some variation from test to test, which could also cause a lot of concern. Oh my gosh, I lost 3%, but that could be the amount of error between the tests from one test to another. So
Absolutely.
it's not the best test out there, but it's the most globally available test out there.
Okay, I see. So you get in, you mentioned some other tests. There's
Yeah.
um gosh, I'm
There's a
thinking of the last one you were referring to, but there
Yeah,
was a
the
few more.
RAMs. I didn't talk about it much in there, but
Yeah,
there's a test called a RAMs, which is an ultrasound.
that's what I was referring
Um,
to.
and I love that test because it gives you the same T score. I would argue probably more accurate, but there's no way to know because there's nothing to compare it to other than the DEXA. So you never know when they're different which one's right. It's hard to
Right.
know. But it also gives you a fragility score. And this is what I think is really helpful. And if people have access to it, I think it's great because let's say you get a T score of, let's call it, pretty bad osteoporosis, a -3, right? And you're like, oh my gosh, I'm going to fracture if I cough. You say, well, let's get a REMS and let's see what it looks like. And so you get a REMS, and let's say the T score is, maybe the same, right? Let's say it's the -3 or -2.8, but you have really good quality bone. Then we still want to treat it, right? Let's still make a plan for your osteoporosis, but you don't necessarily need to worry that you're going to fracture by, getting up. You're going to pick up your grandchild and have a spine fracture or a hip fracture. I can't say that that's not going to happen, but it's not as likely, right?
Right.
And so that fear and anxiety that goes along with this diagnosis of osteoporosis can be mitigated by having something that tells you what your bone quality is like.
I see. And referring one more thing on this, when you were talking about the DEXA scan, you were saying that the analysis only shows the bone mineral density,
That's
and
right.
it's not including this whole picture of the bone itself.
Right. Right. It is
Correct?
just telling you about the bone's ability to reflect X-rays, right?
To
Because
really
what an
think,
X-ray
okay,
does, right? And so it's a two-dimensional. It's shooting X-rays through your body, and the minerals will reflect it back, and that's what a DEXA picks up, just as if you
right.
were getting an X-ray for a broken wrist or whatever.
Kind of reminds me of general medicine at times. Anyways, we're going through it. We're 65 years old. We just did a scan. Now we got it back. We got osteoporosis. Next, most doctors would allude to pills. Is that
Right.
what you experienced?
Yeah. So generally, what happens is you'll get a scan, and this is in the ideal world of the traditional medical model. But ideally, you would get screened appropriately. So 65 or 70 or earlier, if you have one or more of this long list of risk factors that most people have, but most people don't check. So anyway, you get the DEXA. Your doctor says, "Okay, you have a T score of this," and then they should, in my opinion, look at what your fracture risk is, and if there's a tool out there that's free and widely available called Frax, Frax. So if the Frax says that you meet certain thresholds of the risk of fracture over the next 10 years, then a pharmaceutical is recommended, and that threshold's pretty low. And then the Frax even goes on to say you could even consider pharmaceuticals if it's lower, if you feel like it's clinically relevant. So what I see is a lot of doctors don't actually calculate the Frax. They just say, you've got osteoporosis, let's go on a drug. Um, and then the challenge is, let's say you're 65, or let's make it a little bit worse. Let's say you're 54. Like you're a woman that just went through menopause. You're in your early to mid 50s. You got a DEXA because maybe you had a risk factor, or you requested one from your doctor. So you're 54, you have osteoporosis, then doctor says, here, go on this drug. Here's an oral bisphosphonate drug that I recommend for all my patients who are on osteoporosis, right? So
Right.
that oral bisphosphonate drug you can take for either 3 years or 5 years, depending on which research you want to believe. And you were 54 when you started. So let's say you finished that drug and you don't have any side effects and you could tolerate it. And maybe it helped your bone mineral density a little bit, but now you're 59. Now what do you do? Right?
What a
What's the
long
next step?
time to be on a pill, too. 3 to
Well,
5
and it's
years?
this is the challenge is that when you use a pharmaceutical approach, you have to be on a drug indefinitely. And they'll talk about drug holidays, but unless you have a comprehensive plan, what are you going to do? Like what are you doing on the drug holiday? You're just watching your bone get worse, right? Unless you have created a reason for yourself to not lose bone, you didn't change anything about your bone metabolism. So the expectation is that your bone will get worse, right? So I just think that the drugs are very short-sighted in general, and without understanding why you're losing bone, are you losing bone? Why you're losing bone? Are you having a hard time building bone? Without knowing those things, then why are we creating a treatment plan that we don't understand what our goal is? Plus, the side effects are significant, and people don't want to take them.
Yeah, definitely. And that it seems for a lot of prescriptions, pills that get recommended to people that don't help and that just come with side effects. And now they have to be on it. Maybe it's a statin, maybe it's a GLP antagonist, maybe it's whatever, right? But we did this traditional model. You went through it. You noticed that we're only treating as we saw it. But now there's a whole different approach. You got training.
Yep.
And I want to go into how you're looking at osteoporosis and what you're doing in your clinic. And the
Yeah.
first chapter that really caught my attention was about nutrition. And before that, it's so funny. I looked at your Instagram and you made a post saying gut health and bone strength. And I was thinking, what is this guy talking about? Gut health and bone strength.
Yeah.
Most people think that's crazy, right?
Right. Well,
L-
maybe.
besides you,
Probably,
but
probably,
let's get
except for
into
me.
nutrition. How
Yeah.
does this help the bones? What are we doing here?
Yeah. Well, let me just lay out the framework for this, and then
Okay,
also I'll say that our framework doesn't exclude drugs because there is a time and a place, I think, for the pharmaceuticals. They're
got
just
it.
grossly overutilized, in my opinion, and there is not a comprehensive plan in place. Because to make a comprehensive plan, you have to have a framework that the traditional medical model doesn't have time for, doesn't have the
Right.
resources for. Um, it's just not what it's made for, right?
You're
So
seeing the doctor for 5 minutes and then he has
yeah,
to go
I
to
mean,
another patient.
and I'll get people saying, our YouTube channels, we have a lot of comments on our YouTube channel, which is awesome. But people have so much anger toward their doctor. Why didn't they talk to me about this and that and the supplement and exercise and how to do this and how to do that? And I'm thinking, when would they do that? Like at what point in the 5-minute conversation that you had with your doctor could they have had that conversation?
Hey, go
And it's just
tan
not what
and
the model is designed for, right? And
right.
that's assuming that they would actually know the material that they could then impart to you, which is also not what they're trained to do. So I don't think we can fault them for that. Like their goal is to prevent fracture, and my goal is to prevent fracture. I'm just doing it in a different way, and a way that I think most people are wanting. And I would love for that to be the standard of care, but it's not in our system. It is not going to be the standard of care ever,
Right.
unless we change the system, and that's a conversation for another day.
Absolutely.
So the framework then is, as I alluded to earlier, you have to understand what your starting point is. And so we've created this kind of what we call the 4R framework.
4R, yep.
And the 4R, the first of the 4Rs is to recognize why you're losing bone. I could almost change that to say, am I losing bone? All right. But most people are losing bone to some extent. And so we want to know, why are we losing bone? And that takes testing. That takes some questioning about your history. What about your genetics? Are you on any drugs, over the counter, prescription? Do you have a history of eating disorder? What does your diet look like, et cetera? Figure those things out. And then we create a plan that is going to be aimed at those things. And so this, as I mentioned earlier with the drugs, if you are on a drug that will, like a drug that will slow down bone loss, but you're not losing bone, it's not going to help you very much, right? If you're on an anabolic drug, but you're rapidly losing bone, it's not going to help you very much. So even if we were to go that route, I would still want to know this information because it's going to help us to determine what's the right thing for you. So then our framework around how to actually fix this is actually based off of the first company we started, which was in health optimization in general. So I kind of have two parallel companies. It's the same team. One's called Optimal Human Health and the other one's called Optimal Bone Health. And the Optimal Human Health side, we create programs that essentially are the same, but different goals. But we start with what we call our pillars, our foundational pillars. And those things are the things that you would expect. And you just mentioned diet. So that's number one, right? We got to eat the right stuff. You need the building blocks. And then you add all the other stuff in there. So exercise, sleep. We have the challenge of the fourth one, which has now become 4 ones. But this is spiritual connection, mindset, stress mitigation. I think all these things that really, if we don't do something about, will eat at us and will prevent us from being successful. So you have to deal with all of those things out of the gate. And then you kind of march your way up with targeted supplementation, hormone, either optimization or replacement, peptides and pharmaceuticals, right? And in that order. And that way for us, by the time we get to the pharmaceuticals part, we don't need any, right? Because we have
Absolutely.
created a program that's going to solve the problem without it, usually, not always.
Mhm.
But to answer your question about diet, a diet that is optimal for building bone is going to be a diet that is going to be optimal for building muscle, right? And so, to look at this, we really need to look at the literature around what does it take to build muscle. And this is where there's so much controversy in this bone health space. And so I walk in here and I start talking about getting adequate protein, and people look at me like, but what about my pH? What about my urine?
Come
I'm
on,
measuring
bone
my
guy.
Yeah. I'm measuring my pee and my urine is acidic. So I must be losing bone.
Get the
Right.
pee
And this is
strip.
like the comments on YouTube are aggressive on this topic. And so there's something that happened in the bone health world. And I don't know how long it's been like this since, I'm not a part of it for a long period of time. But there's some literature that came out, decades ago, on this topic of pH, and this concept of alkalizing your body has been around forever. But I think what's really happened over the last couple of decades is as um, the level of disparity between those that want to eat meat and those that want to eat a plant-based diet has gotten bigger, as the voices have gotten louder, and this has been amplified by social media. Um, Now we're in a place where this pH conversation has really taken on a sort of a thinly veiled form of plants, no plants. And so so I see the plant population, the vegans, vegetarians, and advocates for eating a solely plant-based diet, really leaning on this. You have to alkalize your diet or die. Um, but the thing is whenever this happens, and I'm actually recording a video later today on this topic, whenever somebody touts eating an alkaline diet, there's some interesting things that always occur. So if they're doing a good job, they will quote literature and they'll cite studies that demonstrate that bone loss occurs with a non-alkaline diet or an acid-forming diet. And that's cool. So then if you read those studies, you reliably see the same thing, which is these are studies that are either done on small animals and unrealistic situations, or they were done in petri dishes on bones that are being, or cells rather, that are being cultured, not in the body. In the real world, in humans, restriction of protein, which is what they're recommending, does not have the same impact. And we see very clearly in large cohort studies that if you are vegan or vegetarian, your risk of hip fracture goes up, the risk of spine fracture goes up, and substantially. And so,
Absolutely.
I fight this pretty hard, because my perspective is you need to eat an adequate protein diet. It needs to come from animals if you want to absorb it as well as you can, and eat as little of it to have the best impact. Eliminate the rest of that conversation, of which I'm happy to debate. But just from that perspective, this is where we need to start the diet, and then add potentially other things that could be quote unquote alkalizing. But that's not why you need them. You need them because you have, minerals and vitamins in them. And so that would be, non-starchy veggies, and then starchy veggies, and then fruit. And then really for me, now not all my patients follow this, but for me, that's all you need. You don't need anything else. You don't need grains. You don't need beans. You don't need nuts. You don't need anything other than those things that I just mentioned, because those are our primary food sources. And most of the well-tolerated diets, like the Mediterranean diet, for example, you can draw circles around some of those things and eliminate them and still follow those dietary plans. So that's what I
Absolutely.
recommend for people that are on this journey to improve their bone health. But I get a lot of negative feedback because of the pH thing. And so I'll just say one more thing about that, and then I'll step off the soapbox, which is other things that are acid producing would include wheat and a lot of grains, would include alcohol, would include sugar. And so I don't hear a lot of people saying, don't drink wine and eat chocolate to alkalize your body, right? All they say is don't eat red meat. And I think if you want to avoid grains, alcohol, and sugar, then absolutely do that. You'll be better off for it. But it's not because of the pH effect, right? Our body is so good at buffering pH that you really are not going to impact your pH based off of what you're eating, assuming you're eating a whole foods healthy diet.
So you're telling me after a long night of pasta and drinking that drinking my wheatgrass shot in the morning won't alkalize and balance my pH? This is nonsense, guys. And he's absolutely right. What I love about Dr. Doug is that he follows what I, idealize or make my own the traditional foods approach. It's just how our ancestors ate, guys. Animal foods, wild vegetables. What else? Fermentable foods, living
Mhm.
real foods. I like the whole idea of like support like. I like the fermentable dairy. I love everything that you're saying about this. And he's right. These things, what I've learned about bones in my very short span of learning about bones is that minerals are very essential. And when
Yeah.
you're eating things like grain and sugar and beans and whatnot, a lot of these have these anti-nutrients or these phytic acid, just copious amounts of
Oxalates.
phytic acid and all
Yeah.
these inhibitors that steal minerals from your body, right? And can cause gut issues and all of this. So this approach is truly a fundamental approach to life. And Dr. Doug's spot on with all of this. So approved. Let's continue.
Great.
Yeah, man. That's just
Yeah.
great. We love
And,
it.
and that's and that's one of the biggest things out of the gate is figuring out, okay, what are you eating? And then
Yeah.
we will often have this conversation around vegetarian and vegan diets, because so many of the patients that are coming in are vegetarian or vegan, right? And so
Right.
we're asking the question, okay, so why are you following this way of eating? And if it's for health, let's talk about that. If it's
Yeah.
for ethics, we can talk about that too. If it's for the planet, we can talk about that too. But from a health perspective, it's not going to help you to it's not going to help you to get your goals, right? And so we go through that. But then there's also the question of, are you able to absorb the nutrients even if you're eating the right diet? And so this is where gut testing is one of the primary things we do, from a functional testing perspective, to look at, what are your enzymes? Are you able to absorb food? Do you have issues? What's your microbiome look like?
Right.
We do that for everybody now that comes into the bone health program, because we found it was needed by everybody. So instead of adding it on later, we were like, look, let's just make it part of the program because everybody needs it. And it's been really eye-opening, because we see some of the same dysfunction across the board with not having enough hydrochloric acid in your stomach, for example. A lot of people that are on PPIs or drugs that reduce stomach acid. We see issues with the microbiome. We see issues with other enzyme function like pancreas enzymes not being able to break down protein or tolerate dietary fat. So once you see that, then you can say, okay, well, now we need to have this gut health program that'll help to fix this problem. And then we fix the nutrition, and then we can actually start absorbing nutrients, right? So now we have the building blocks. So then you have to say, well, what kind of exercise are you doing? And can you do resistance training? And what other stuff can you do? And so we put people on a program for that. We talk about the other things that I mentioned. So we talk about sleep hygiene, and we talk about stress mitigation and connection and spiritual health. Those are harder to really nail down. So that's really one-on-one interdependent. But then we create a custom supplement plan based off of biomarkers. We talk a lot about hormone replacement, because a lot of
Yeah.
our, especially women, are peri or postmenopausal. So much confusion around that topic. So we are huge advocates of bioidentical hormones, can play a major role in this process. And then we also talk about peptides, and I know you wanted to talk about that. So
Yeah, for sure.
yeah. So so direct me. What do you want to hit next?
I want to go to a couple segments, and we're talking about how this osteoporosis is a ghost disease, one of the major chronic diseases and life-threatening ones. What are the 5 risk factors for osteoporosis?
Yeah. So I think, clarify your question. Do you want to know risk factors, or do you want to know things that can cause bone loss?
The other one,
Yeah,
the latter.
I can say it a couple of different ways. So I would say the primary things that cause bone loss, number one, I would say is not having good bone in the first place. So a big misunderstanding about bone health is that we are creating all of the bone we're ever going to have early on in life. So actually, as an adolescent, as a young adult, you are developing your peak, what's called peak bone mass. That happens for most people in their early 20s, maybe by 30, right? You have all of the bone mass that you're ever going to have. And then it's a downhill slide from there. Now, I would argue that slide does not have to be as steep as it is in most people. But think about it this way. If you have a low starting point, even if you do a really good job of maintaining your bone mass, you're still likely to be osteoporotic by the time you're 65. So understanding what that looks like, and getting a good diet, for especially for women, although I see it a lot in men too, not having an eating disorder, eating whole foods, eating an adequate protein diet before you have the problem, because it's good for everything else too. So that's probably number one, is not actually achieving good bone mineral density in the first place. Number two is going to be hormone dysfunction. And this is true both for our peri-postmenopausal women, but also premenopausal women and men, because hormone dysfunction is rampant in our society for a lot of reasons. But
Yeah.
for women, I think birth control is one of the biggest ones, because the synthetic progestins in birth control are known to cause bone loss. If you
Interesting.
obliterate a woman's cycle, you lose that back and forth of that seesaw of the estrogen and progesterone. When you do that, your bones will suffer. You need that back and forth to build bone. So I'm seeing a lot of younger women in their 30s and 40s with osteoporosis that we're working with, because they were an athlete, they had challenges with eating, getting enough nutrients in, being energy depleted. They didn't have a cycle. They were put on birth control. Like, I see this all the
Yeah,
time.
absolutely.
And so that's a big one for younger women. And then obviously, every woman, if she lives long enough, will go through a menopause. And that is a time at which you have to have the conversation and make a decision for yourself on whether or not replacement is the right thing for you. And if it's not, then making sure that you understand what your starting point is with bone loss, because it'll happen. It's predictable. Men are kind of the same thing, but not as obvious because testosterone is the primary sex hormone. It aromatizes to estrogen. That's what prevents the bone loss. If you have low T, you're going to have low estrogen too. And that's a big problem for men. So I would say about a third of our practice right now is actually men with osteoporosis.
Interesting. And
Yeah.
there's, I mean, the amount of environmental risks and BS that's out in this world, all the chemical disruptors of the endocrine system, that's kind of like birth control too. Not bringing it to that extent, but you understand all these just
Totally. Totally.
chemical
Yeah.
soaps in the food and the seed
Hmm.
oils, and you're spot on with all this. The
It's
crowd definitely knows what
yeah,
we're talking
it's
about.
everywhere. It's really tough to avoid. So hormones, I would say, would be number two, and then number three would be diet.
Diet,
Poorly directed diets, being misled by things that you're reading or listening to on social media.
right?
Number four would be gut dysfunction itself. Not being able to absorb nutrients, and then I would say number five would likely be, I would just lump together drugs, drugs, um, because so many drugs can cause bone loss. The most common of those being for acid reflux, but there are a number of drugs out there. Steroids is another big one that can have an impact on bone loss.
Hold on, bro. Steroids, bro? Is that what you're talking
Yeah,
about?
yeah,
The anabolic steroids?
not those steroids. No, uh,
Oh, okay, okay. Oh,
corticosteroids. No,
okay,
anabolic steroids
corticosteroids.
corticosteroids. Yes, anabolic steroids would build bone. Not much of an expert in that space, but I would just assume if you're being anabolic, your bone would be anabolic too.
Okay, back. So I love this concept. If you're building muscle, you're building bone. Absolutely. The nutrition. And the nice thing about this gut thing is that that's why the bones aren't dense and nutrient filled, is because you can't absorb these nutrients. Also, one more thing about nutrition. Have you ever heard of the theory of like supports like?
Mhm.
Meaning when you eat, bone marrow, you're getting phenomenal growth factors, and the cartilage is helping you with collagen. And eating scapula can help with your scapula or something,
Yeah.
right?
Yeah, we see that in functional medicine a lot. If you can use, desiccated organs from the different organ system, and it will have an impact. So, thyroid for thyroid, adrenal for adrenal,
Would you recommend that with your
testicles
patients?
for testicles.
Yeah.
I haven't spent a lot of time looking at research on it. We use desiccated thyroid for thyroid dysfunction
Oh,
because that's
nice.
an actual pharmaceutical, although not FDA approved for it. But we use that for sure. I haven't used adrenal glandulars before for people with adrenal dysfunction, like
Yeah.
severe stage 3 adrenal dysfunction. I do see some benefit there. I haven't done much else though, because I haven't really looked into the literature. I don't see a lot of need for it.
Hmm. Okay, cool. We got these 5 risk factors down, or the 5 ways to prevent bones.
Yeah,
I I was wanting to go into 5 ways to get better bones.
yeah,
Does that make sense? Can
yeah.
we?
So let's backwards step those five risk factors you just
Yeah,
said,
let's
right?
do it.
Yeah. So I would say if you start with number five, identify if you're on anything that's causing bone loss, right? So I mentioned PPIs, corticosteroids, progestins from birth control, or poorly done hormone replacement, in my opinion.
Yeah.
There are a number of other things out there, but those are the big ones that we see. So that's number five. If you're on them, see if you can get off them. Don't just stop taking them, but see if
Right.
you can get off them.
Right.
There's a time and a place for all those things. But if you don't necessarily need them, then see if you can get off them. And then number four was, what was it? Was it gut dysfunction? I think it was gut dysfunction.
Yep.
So
Gut
that would be
dysfunction.
doing some testing. So functional testing on your gut. What does I mentioned all the enzymes and your microbiome. That's a stool test. So a little icky thing to do, but it gives you a lot of information. Figuring that out, working with a practitioner that can really dig into that for you.
Shout out
Um,
Genova for sure.
yeah, Genova. We use the GI effects. That's the one we use. Yep.
Certified.
Um, and then then nutrition was the second one. So we've already kind of hammered that. And then hormone optimization or replacement. And this is where, man, it's tough to find the right provider, because finding somebody who understands hormone optimization rather than just hormone replacement. And so for men in the traditional medical system, you're not going to be offered replacement in general unless your levels are really, really low.
Yeah.
To actually meet the criteria of hypogonadism or low testosterone, your levels need to be, it's always changing, but under like 290
It's crazy.
per total, which is really, really low. So I see people that are symptomatic that have total testosterone 4, 5, and 600, but it has to do with how it's being metabolized. So what's your SHBG? How is it being, aromatized to estradiol, et cetera? So if you test all those things and they have the symptoms, you potentially might be a candidate for some kind of optimization or potentially even replacement. Obviously not FDA approved, but it's out there. But you got to find the right provider that understands it. The challenge in that space is that some people have created companies that will drive it, I think, a little too hard. And so then you got guys that, their primary care doc says, oh, your testosterone's fine. It's better than mine. Right. And then they feel terrible. And then their buddies on testosterone that, looks like the Hulk. And they're like, dude, I want that. So then they go out and online and they find testosterone, but then they like just get ramped up way too high. Right. So then
Absolutely.
they have emotional disturbances. They've got
Yep.
acne, they're balding, their testicles go away. They're like, uh-oh, and so then they're like, well, it's not for me. You're like, well, no, it just wasn't done well,
Yeah.
But the same thing happens in women. So when
Yep.
young women will go to the doctor and complain about hormone issues and they'll be put on a pill every time. Older women may or may not be recommended to be on hormone replacement, most likely not. And it's because of this fear of the risks, which is a conversation for probably another day. But, those fears are real-ish, but I think grossly overstated. And so it's hard to find somebody that will do it well. And this is a big challenge. And I don't even know where to direct people.
Yeah.
And then, number one, well, you can't fix number one because that's where you started.
Yeah.
But if you're younger, if you're a younger person, understand that how you eat in your teens and 20s will impact your risk of osteoporosis in your 50s, 60s, and beyond. And you make sure that you are getting a good diet. Don't worry about being extra, extra lean all the time. It's not normal. If you need to get lean, but then, don't forget to grow. You got to be anabolic at some point too. So you got to balance those things and then know. I mean, I think it's great to get a DEX. I get DEXs on all my patients, right? Because we're looking at body comp, so that can help from a performance perspective. But then also I've picked up, and I had a mid 40s woman who was there for, she's body comp performance. Did not expect to see it, but when we got her DEXA back, it was just sort of like hidden, it was like, oh yeah, and by the way, you have osteoporosis. Like, wait, what?
It's crazy, man.
No idea. She's just like this muscular athlete, you're like, wow, that's really surprising. So, so I think knowing your starting point, then going back to that number one.
Okay. We need to find a way to bring this all together. I really want to highlight your clinic, right?
Yeah. Yeah.
I really want to talk about the amazing things that you're doing. We'll edit this out as well. But now here we are. We have this great framework, this 4R framework that you started working on after learning about the traditional medicine model, being in it, seeing osteoporosis, what it does to people, and now we're here. Let's talk. I'm your patient, and I came to you. I got osteoporosis, man. We're gonna go through the things, but I know every case is patient by patient.
Yeah.
But let's just start with how you look at it now after knowing everything that we just discussed.
Yeah. So we have essentially created those frameworks that I described. And what we did with the practice is that we essentially turned it into like a membership model. So when we first started, we were doing kind of the one-off consultations, the traditional kind of functional medicine gig, right? Where like you go see the doc and they order a whole bunch of tests and you have a follow-up and you're like, you need all this stuff, right? It's like so overwhelming. And it's like some people would do it and that'd be great, but a lot of people wouldn't because it's overwhelming. Like, what do I do with this list of stuff? Like, where do I start? What if this supplement makes my stomach upset? It's just it's so tough in the traditional in the traditional functional space, right? So this is like outside of the traditional medical model, but creating a model where we could support people the way that we wanted to. And I knew, coming out that I wanted to create something different. And I'd seen membership models out there, but they were generally more performance driven, and for people that weren't sick and didn't need a lot. So our goal was to say, well, let's combine this like functional medicine model with this membership style with the effort to say, look, let's get people in the door. Let's provide them with everything they need. So we're not nickel and diming them with everything. Like, it's going to be an investment. Let's just not hide that fact. Let's say, look, for the doctor's visits and the report prep and the concierge ordering and the support that you get and the daily access to people and unlimited coaching, this functional test for the stool, like all this stuff, it's going to cost some amount of money, right?
It
So let's just
is.
put that out there, right? And so we do that. We bring people in the door. That way, there are not surprises. So then they come in the door. They meet with the coach. They talk about their nutrition. They talk about their lifestyle foundational pillars. We get the blood work, decide if they need functional testing now or later, and then get the objective data. And then they sit down with me and my PA, or it's going to be starting next month. It's going to be me or my PA, which will help with the cost a little bit. And then you go over those results review and you come up with this plan based off of all those things we just talked about. And then you do that over the next 5 months. And then we repeat the labs and then we, course correct. And then we go again. So we bring people in for 12 months because we want people to have that time to not feel rushed. We started out doing 6-month memberships. What we found is it's just too rushed. People are like, what, but I gotta get it in, and 6 months is kind of a long time, but a year's comfortable. And it's of course, then it's a bigger investment because now it's double the time. But what we're finding for osteoporosis, especially, is that it takes time, to see these things turn around. And I mean, actually our continuation rate, the number of people that will continue on with us after our first year, is around 90%. So what we find is that people, when they join, they don't want to let go, right? They love the model. They love the support. They love the fact that, like, when they need a new supplement or they need a peptide or a hormone, like, they don't have to chase it down and go to 15 different doctors. They just reach out to my person, right? They're like, oh, Tiffany, I just emailed Tiffany, or Tiffany just sent me this form and I can just check the boxes and then it's done.
Yeah.
That level of care is honestly how we should all be treated. But for now, for people that have an identified problem like osteoporosis, this is how we do it.
What are some biomarkers to look out for bones?
Yeah, that's a great question. So our panel is, 300 plus biomarkers, but the thing specific for bone, once you know why you're losing bone, then we can even cut it down more. And I'll just give you 2 that people can take away with. So one is the CTX, which stands for C-telopeptide. And that is the biomarker for bone breakdown. Bone breakdown is your osteoclast breaking down bone. And if you're rapidly losing bone, it'll be high. And if you're not rapidly losing bone, it'll be low. So that's awesome. And then P1NP, which is the biomarker for bone building. So you want to know if you're making bone, you want that thing to be as high as possible. Now, the challenge is with those two is that knowing what the reference range should be is tough, because when you look at the LabCorp reference ranges or Quest reference ranges, they're statistical averages and they're based off of age, right? So if you are expected to be rapidly losing bone at 55, the CTX reference range goes up to like 1200. If you're at 1200, you are rapidly losing bone. That's not normal. It's not okay. So, so that's where, like, understanding where those reference ranges are can be tough.
Interesting. Okay. We got my biomarkers back. First step, we're fixing it up. I want to get into peptides. Let's say we got all the bases covered. What kind of peptides are you giving to your patients for bones or other functions?
Yeah, so we have a long list of potential peptides. There are no peptides that are specific to bone health, though. And this is where, like we say, well, this peptide builds bone. Well, I don't know any of those peptides, but there are some peptides that indirectly will impact bone. And so I look at the class like the growth hormone secretagogues. Growth hormone secretagogues like sermorelin, ipamorelin, CJC, ibutamorin. These peptides will increase IGF-1. And that will put us in that anabolic mode. And in that anabolic mode, we will build both muscle and, in theory, bone, although I've never seen it in research. The other class that I really like is the, again, growth hormone-ish, but not growth hormone, is to use something called AOD 9604. AOD is a fragment of growth hormone. It will have an impact on muscle growth. But for people that are in a weight loss concern, people that are trying to kind of split the gap and do both, which I don't recommend, but people that want to lose weight and build muscle and bone, AOD is perfect for that because it stimulates hormone-sensitive lipase. It's triggering fat burn, but it's also triggering muscle metabolism. So it sort of it's like the body comp peptide, right? Now, to be clear, none of these things are FDA approved at all, and definitely not FDA approved for osteoporosis. So just to put that FTC trademark out there. Yeah.
What about copper tripeptide? Have you done any research on that?
I haven't. I love copper though. I got some copper right here, but the only places I've seen copper My copper. The only places I've seen
What's
copper,
that?
it's a copper capsule.
Oh, really? Okay.
Yeah. The only places I've seen copper used would be topically. Is there an indication that you know of for muscle or bone?
So I was looking into subcutaneous copper
Hmm.
tripeptide, and
Hmm.
gosh, I was reading one journal. Forgive me. I believe it targets. There's two types of collagen, correct? There's these collagen 1 and collagen 2,
Yeah,
and I
that's a
believe
bunch.
it signals one of these one or two collagen. Gosh, it signals to make more collagen, which inevitably can help with
Yeah.
regeneration.
Maybe like type 1, they call them like
Type
type
1,
1
yeah,
specific collagen. Yeah. So type 1 is the most common collagen in bone. I'll take a look. I'll look it up. As you mentioned, I'm a member of the International Peptide Society, so I'll see what they say on it. I definitely seen copper used topically.
yeah.
And I think that we are likely all copper deficient based on some research that I'm doing right now. So that's why
Interesting.
I'm taking copper and I'm starting to implement it for some of my patients. But more to learn on that. Ask me again in about 6 weeks.
Okay. We're now walking the walk, talking the talk. Lastly, I want to go through a daily routine for Dr. Doug, what he does to optimize his bones and his
Yeah,
health, and
yeah,
how it goes on to his patients. Because the funny thing is, in the traditional medicine model, which you're not in anymore, you notice that a lot of people are saying, do this, do that, do that. They're not even doing it themselves.
sure.
Rather, they're just hurting and this and that. But I want to hear what you do, Dr.
Yeah,
Doug. So if you
yeah.
just want to go through daily, the nutrition, the four R, whatever, let's do it.
Yeah. And so for me, I mean, I actually do have osteopenia, but just like barely, and it's been stable for decades. So I'm not actively trying to improve my bones. I just don't want them to get worse. So a little bit different than where a lot of my patients are. But for me, I'm more interested in health span and longevity. So my day is driven around, really for me, it's a lot driven around routine. I start by making sure that I'm getting adequate sleep. So that starts the day before, right?
Absolutely.
I get up at the same time pretty much every day, weekday, weekend, doesn't matter. I give myself about a 30-minute, leeway there, but for the most part, I'm up at 5:30 or 6 every day. I have a morning routine that for me includes meditation, a cold plunge, I walk the dogs, I journal with a cup of coffee, and then I have my first Zoom meeting at 6:30, 6:45.
Oh, wow.
Um, yeah, and,
Let's
and
go.
and so then I start. Yeah, so it gets my team on their way, right? So we've got 15 people on the team. So we gotta push people, not push. We have to direct, um,
Encourage. Let's go.
and because they're all motivated people, they're doing what they need to do. They just need the direction. So then I have what I would call deep work. So this is sort of like the development, the research, the stuff that's just me and my brain and my computer usually do that for 2 hours, 2.5 hours, and then I train. So then I have an hour and a half to 2 hour training block. So that's working out, that's zone two, that's hill walking, rucking, sauna, whatever.
Hmm.
So all of that depending on the day. And then afternoons are usually meetings or patients. So I kind of alternate meetings, patients. And then Mondays and Fridays, those afternoons, like today, Friday afternoon is a content day. So Monday and Friday are content days.
Amazing.
Yeah.
Getting to the workout, we kind of overlook this, but resistance training is crucial for bone strength, right?
Yeah.
You need to
Yeah.
have a load. And that's what was that quote that was in your book? Something about a
Uh,
load, the Rudd quote. It was like without the gosh, the impact of resistance on
yeah.
your
So
skeletal system. Yes,
Wolf's
yes.
law is in there. I have a lot of quotes in there. But yeah,
Can do.
Wolf's law basically says that bones will remodel based off of the um, what's the right word? The load. I think this says load.
Yeah.
So based off of the load that they perceive, right? And so this has been shown throughout the years. Julius Wolf was a surgeon in the 1800s, and so he saw this impact, and it was in people that were basically jumping off of like vegetable carts. He was looking at people's bones, and so he looked at this in animals, and it's definitely true. If you load bones a certain way, they will respond to that bone, and they will grow more bone, right? So that's cool. You can put that into play with humans by saying, what are the things that load bone? Well, it's gravity, it's resistance training, it's impact. And there's an interesting franchise out there called OsteoStrong, which sort of brings them all together. And they coined the term osteogenic loading, which is basically just a way to say you are loading multiples of body weight through your bones. And so, yeah, you have to load them somehow. And I see this in patients where they might have all the building blocks, but if they're not provoking a stimulus, then they're not going to build bone. And so you have to provoke a stimulus. You have to do something, or rely on like a drug. So yeah, resistance training is one way to do it, but it's got to be pretty specific and it's got to be pretty heavy. And this is where people get into trouble, is because they're like, well, I got my 5-pound dumbbell, and I'm like, that's not it. It's not enough. The research that's been done on this will show that the patients that improve are the people that are doing, they're doing like a back squat. They're doing, deadlifts. They're pulling up on a pull-up bar and then letting go. Right. And impacting on their heels. So yeah, you've got to provoke a stimulus, whether it be through resistance training or some kind of an equipment like OsteoStrong. Biodensity is another company that's similar in that way. So whole body vibration plate's another one. Wearing a weighted vest is another one. Like there's a lot of ways to do it.
The vibration plate. Interesting.
Yeah, vibration plates will do it. Yeah, it's interesting. The mechanism behind that's interesting, but it's predictable in literature that if you stand on the right vibration plate, it'll improve your bone mineral density.
Well, man, Dr. Doug, this has been freaking party of bones. Honestly, we learned so much. I'm going to wrap it up by summarizing what on earth did we learn today. We always start with the traditional medicine model. We learned about your story, your way of how you got into bones. We learned about how traditional model looks at allopathic medicine can look at bones and osteoporosis in general, the chronic risks and disease that comes with osteoporosis, and death that might occur from it. And then we learned about the way to do it, the way that you approach osteoporosis, and how to prevent it in the first place, and also how to fix it once you receive it, right? So we went through your 4R method, which is recognize. What was the second one again?
Recognize. Actually, I didn't actually say any more than the first one. So recognize.
This has been all over the place. I apologize about that.
Reverse those causes of bone loss. Retest to make sure you're headed in the right direction, and then revive your life and live without the fear of fracture.
Absolutely, man. So we're putting all these resources down, by the way, guys. But I want to get you on because this is one of the most important topics that is on this podcast today, guaranteed. Bone health is essential for life. Without it, you lose your freedom. And your approach by recognizing what your bones are for what they are, getting a holistic system down, just like yours, meeting with someone like Dr. Doug Lucas, using proper nutrition and health and spirituality. You had a post on Instagram. You were saying 3 things that win the day. It was training your spirit, your mind, and your body. That's on my wall now. I'm not even kidding.
Love that.
Because you're a motivation. The way you look at things now it's different. It's advanced. And I appreciate it, man. We got into peptides. We got into a whole bunch of stuff. It was sporadic, but there's incredible benefits to be gained from listening to this. Yeah. So thank you, Dr. Doug. Any last remarks, man?
No, I think the thing I'd like to leave people with is just remember that whether it's bone health or diabetes or dementia or cardiovascular disease or just feeling better, just remember to be an advocate for yourself, because the traditional medical system, like we said, is great at stuff, but it is not good at elevating people to where most people want to be. So be an advocate for where you are. And if you're not feeling as good as you want to feel, then find somebody to help you figure it out.
Absolutely. We have the power, guys. Thank you again. God bless Dr. Doug. Dr. Doug Lucas out. Jack is out. Thanks again.
Thanks.
Cool. All right, man. Thank you so much.
Cool, man. Yeah, that was awesome. I really appreciate it. And actually, right as you were finishing up, my phone started ringing. I got to hop on this, but yeah, send me over anything you want to send out. I'm stoked about it, and
we're gonna make tons of content. Okay, you're awesome, man. I hope we can meet again soon. Sorry it was so sporadic, but I'm young. I'm new to this. Thanks.
That's all right. Take care.
Bye. Right. Thank you for listening once again to the Kool Health Podcast. I hope you found some meaning out of this episode. Share this with your friends. Like and subscribe for more. Thank you once again.